In this video, I'm going to talk about calcium metabolism, perhaps along with phosphorus metabolism. I'm Dr. Baskaran, Associate Professor, Department of Biochemistry, SLIMS, Pondicherry. In this session, at the end of the session, the learner should be able to describe perhaps on these objectives, what is called specific learning objectives. Data sources and audio of calcium, functions of calcium, because calcium is the most important microelements, and the distribution of calcium in blood, normal levels of calcium and its regulations, homeostasis, disorders, biomedical importance, that includes hypo and hypercalcemia, phosphorus metabolism, and the disorders. Let me start with the minerals. Minerals, among the elements, the carbon, hydrogen, oxygen, nitrogen, these are organic in nature. They only make the core of the life, the biology. So other than these four elements, the rest of them are called mineral, that is inorganic. There are about 15 to 20 are nutritionally important or essential for any life system. They are required in small quantity for normal metabolic activities or functions. That includes homeostasis, for example, regulations of pH, fluid and electrolytes, and it is a water and electrolytes, maintenance, coagulation, or blood clotting. They also act as a component of enzymes and hormones. So these minerals, that's whatever we require, the around 15 to 20 of them, are classified into macroelements and microelements. That is based on the requirements per day. If the requirement is more than 100 milligrams per day, they are called as macroelements. There are some 7. And microelements less than 100 milligrams per day is required. These are called microelements. They are 10. Microelements include calcium, phosphorus, magnesium, sulfur, sodium, potassium, and chlorides. Among them, sodium, potassium, chlorides are called electrolytes. In this session, we are going to talk about mainly calcium and phosphorus. Microelements, they are also called trace elements. There are 10 of them: iron, iodine, copper, zinc, manganese, molybdenum, chromium, cobalt, selenium, and fluorides. Let's start with the calcium. Calcium, as you know, is one of the macroelements. So under the introduction, so we'll give some basics. Then we'll go on to its metabolism, its homeostasis, and its disorders. So calcium is most important and one of the important macroelements, and is essential for bone and teeth formation. The bone is basically calcium phosphates. The total calcium in the human body is about 1 to 1.5 kilograms, and most of the calcium is found in bone, and 1% is in the extracellular fluids. So, as I mentioned, most of the calcium is along with phosphorus present in the bone and small amount in the teeth, but 1% is only found in the extracellular fluids. Sources, good sources of calcium includes milk and milk products. Because they are a very good source, because milk contains about 100 milligrams calcium for 100 ml of milk. This is a good sources. As maybe nature provides this milk, they only feed to the newborn infants. The other sources are egg, fish, beans, lentils, nuts, or the other sources of maybe moderate sources of calcium. Those people who are vegetarian, even some people not taking milk or aversion to the milk, so they can get calciums, fair amount of calcium from beans, lentils, nuts. RD or recommended daily allowances. For it's about 500 to 800 milligrams per day. That means around 800 milligrams. That's for for adults. But children, growing children, it should be 1200 milligrams per day. But in the case of pregnancy and lactation, suppose a woman is pregnant and suppose she's a lactating woman, and these requirements goes up, that means 1500 milligrams per day. As age advances, but the requirements goes up as the age advances. This is actually to prevent osteoporosis. This metabolism is start with absorption. The site of absorption, basically the calcium is present as calcicarbonate and calcium phosphates. Calcium is mainly absorbed in the second or third part of duodenum. It is an active transport and carrier mediator. That means it needs energy as well as transporter. It needs both energy and transport. That's what I mean. Both energy as well as carrier or transport protein. It's called calcium pump. Why this factor affects calcium absorption? For example, pH of the intestine. Acidic pH promotes absorption of calciums, while alkaline pH, it is lowered. High protein diet favors absorption. This calcium dissolves here in this case. Similarly, lysine and arginine favors absorption, increase the calcium transports. Such condition, the absorption is affected. For example, in malabsorption, the fatty acids are absorbed and they forms calcium salts. So they affect the absorptions. It means say they lower the absorption of calcium. Diet containing high phytates and oxalates, present in the greens and vegetables, lower calcium absorptions because they form complex. High fiber diets prevent absorption. In fact, even phytates and all present in the fibers because they form precipitate of calciums. Calcium phosphorus ratio between 1:2 to 2:1 is better for absorption, or the ideal is 1:1 ratio, which is I think that's good for calcium absorption. Anything more or less affect calcium absorption. Hormones, among the hormones, calcitriol, even increase calcitriol, the active form of vitamin D, increases calcium absorption in the intestine. This, however, calcitriol acts in intestinal cells, then promotes calcium absorption. And whenever this calcium is lowered, this leads to calcitriol formation. And that actually comes to the intestinal cell, comes to the intestine. That binds to the receptors, calcitriol receptor complex in the cytosol. That enters into the nucleus, where it binds to the specific DNA sequences. That stimulates transcription of cal-binding protein. That cal-binding promotes calcium absorption from lumen into the intestinal cells. Calcium in the cell, calcium is mainly extracellular. It's a cation, Ca2 plus. So it's an extracellular cation. The cell membrane is usually impermeable or not permeable to calcium ions. That means it needs basically transport. So calcium influx or transport in the cell is by sodium calcium exchange mechanism. Entry calcium in the mitochondria is by calcium aniphore system. That means it transports calcium alone. So it doesn't need any other exchange system. The calcium ion exit or coming out of the cell is through sodium calcium antipode system. This interdepends on the sodium hydrogen ATPase pump. This is called calcium pump. So inside, when going into this particular mitochondria, it's anipodes, but when it exits, it's through exchange system that is called calcium pump. We also have other calcium channels, voltage operated channels, and second messenger operated channels. These other things is the voltage channels, second messenger, regulated channels, hormone regulated channels, sodium calcium exchange channels. This is actually calcium pump. It means here it's into the mitochondria side of things. So the same thing, calcium channels, we have a different type of channels that's called regulated calcium channels. The voltage operated channels, which are activated by membrane depolarization. Second messenger operated channels, which are activated by inositol phosphates, cyclic nucleotides, like cyclic AMP, or diacylglycerol. These are actually basically second messenger. Hormone receptor operated channel is activated by hormones or neurotransmitters. Same thing is just before the calcitriol acted through the receptor channels. So sodium calcium exchanger. Calcium pump will remove calcium from subcellular organs to cytosol of the cell. Now let's come to functions. We will talk about the functions of calcium. Calcium does a wide range of function, and it performs a wide range of functions. For example, it's required for development and formation of bone and teeth, what's called calcification or mineralization, coagulation or clotting of blood, which is one of the important hemostasis. This is actually where calcium is act as involved in the coagulation process. So here it is. It's a factor 4. It will then activate other factors. Muscular contraction. Calcium is very important for muscular contraction. When signals reached, calcium is released from sarcoplasmic reticulum. It activates ATPase and binds with troponin C. This leads to interactions with actin and myosin and contraction of muscles. Functions. We talk about other functions. The nerve transmission, in this case, the transmission of nerve impulses from presynaptic to postsynaptic region. Yes, calcium is important. Activation of various enzymes. In this case, direct activation. These are the enzymes are directly activated: ATPase, lipase, succinate dehydrogenase through colmogylin calcium binding proteins. This colmogylin binds to calciums, 4 calciums for colmogylin for this protein. This complex activates enzymes such as adenylate cyclase and pyruvate kinase. This is how the colmogylin complex activates enzymes. So this calcium binds with the colmogylin. This calcium bonds to colmogylin complex activate various kinases. This in turn activated kinase activate the enzymes. That enzyme is phosphorylated because kinase is the one phosphorylates. That brings about various biological effects, biological function. Second messenger, calcium is second messenger, of course, with the like AMP, epinephrine, and glucagon. And calcium is required for secretion of various hormones like insulin, PTH, calcitriol, ADH, antidiuretic hormones, or vasopressin. Calcium also required for the maintenance of membrane integrity and vascular permeability. Calcium decreases the passage of serum through capillaries. That's one way to make important things. Otherwise, like it's maintenance of the integrity of the vascular permeability. Heart also in the cardiac muscles. Calcium regulates membrane potential and contraction of cardiac muscles. Come to the plasma calcium. Let's take a look at all these calcium is. We talked about only 1% calcium is present in the ECF. Normal plasma calcium is 9 to 11 milligram per DL. This in the plasma or in the blood, calcium exists in three forms. One is protein bound, other one is complex, and the third one is ionic form. The ionic form is most important, metabolic active. So protein bound is about 40%, it's 4 milligram per DL of calcium. It's bound to protein and it's non-diffusible. Complex form of 1 milligrams. DL is around 10%. It's complex with the phosphates, carbonate, and citrate. Ionic form, calcium 2 plus, it's a cation, about 5 milligrams, that means about 50% of calcium is in ions. This is most important one, a metabolically active form. These two forms are diffusible from blood to tissue. This picture shows the distribution of calcium in the plasma. This is actually protein bound, it's 40%. It can't be diffused out of blood vessels. There's calcium complex with the citrate, phosphates, bicarbonates is about 10%. And this ionized form, that is Ca2 plus, it's a matter of active calcium. The ionic form is about 50%. How this calcium is regulated, a level is regulated, or how this calcium level is maintained in blood, we will see under calcium homeostasis. To maintain this calcium within the physiological range, 9 to 11 milligram per DL is very, very important. And it's regulated by three hormones. Parental hormones, PTH, calcitriol, the active form of vitamin D, calcitonin, that is other hormones. This calcitonin is one of the hormones which oppose the actions of parental hormones and calcitriol. PTH and calcitriol tend to rise plasma calcium level while calcitonin tends to lower the calcium level. This picture, before going to the text, I'll show you this is parental hormone is as a peptide hormone with 84 amino acids. It's synthesized as a pre-pro and pro families converted into the active form. Parathyroid hormones, PTH, containing 84 amino acids from parathyroid gland. When calcium level is low, decreases. What happens is it causes calcium absorption. When calcium level is lowered, reduced, this hormones secreted from parathyroid glands act on the bones and promotes calcium absorption. It activates osteoclastic mechanisms and leads to demineralization of bones. So I just repeat these points. Whenever there is a calcium level is lowered, this leads to release of parathyroid hormones from release of PTH from parathyroid glands. This act on the bones causes absorption. by activating osteoclastic cells. It also activates 1-alpha hydroxylase, forming calcitriol. This calcitriol in turn acts on intestinal cells, causes calcium absorption from the lumen in the intestinal cells, intestine. It increases renal resorption, that means lower the excretion of calcium, and excretion of phosphates. I'm going to say it increases renal reabsorption, that means reduces calcium excretion, and also promotes excretion of phosphates from the renal tubules. All this action results in rising plasma calcium. Calcitriol is the active form of vitamin D. This activated first in the liver, 25-hydroxylation, followed by in the renal tubules, 1-alpha hydroxylation by 1-alpha hydroxylase. Finally, is formed calcitriol, 125-hydroxycholocalciferol, or the active form of vitamin D, that's calcitriol. It acts on three sites to raise plasma calcium. One is bone deposition of calcium. That means it promotes osteoblastic activity. It increases alkaline phosphatase, so that favors mineralization of bone, putting more and more the calcium into the bone. In the intestines, promotes absorption of calcium by increasing calcium binding protein. That's called cal binding protein. In kidneys, it promotes reabsorption of calcium along with the phosphorus. So finally, strengthen the bone and raises both calcium and phosphorus in plasma. Calcitonin, among with these three hormones, calcitonin suppresses the actions of parathyroid hormones and calcitriol. It's a peptide hormones containing 32 amino acids from parafollicular cells of thyroid glands, C cell. It opposes the actions of PTH. When calcium level is high, it inhibits absorption of bone, decreases the activity of osteoclast, and increases the activity of osteoblast. It causes excretion of calcium in kidneys, just the opposite effect of parathyroid hormones. That means it lowers calcium in plasma. This, you can look at the picture to clearly explain. When this blood calcium is lowered, that is sensed by these parathyroid glands. So that releases parathyroid hormones, PTH, that act on the bone, causes absorption, so the calcium released, attack on the kidney, activate 1-alpha hydroxylase, produces active vitamin D, that is calcitriol, acts on the intestinal cells, this one. So parathyroid hormones act on intestines through vitamin D, not direct action. So this calcitriol promotes calcium absorption from intestine. So all these things leads to increased calcium level. This parathyroid hormones also decreases calcium excretion in the renal tubules. That means increases reabsorption of calcium. So this is actually, whenever the calcium levels rises beyond the normal levels, so this acts on the thyroid glands, C cell. This releases calcitonin. This actually acts on the bone and also the kidney. In the bone, it's what's called increases the mineralization, what's called deposition of calcium. In the kidney, it causes excretion of calcium. So all these things lowers the plasma calcium levels, bring it to within the physiological limits. Disorders we have in medical conditions, we have among the disorders we have one is hypercalcemia, one is hypocalcemia. Hypercalcemia is where we have the calcium level is below the normal levels. maybe you can say below 8.8 milligrams, where you can clinical feature starts appearing. Now the causes, hypoparathyroidism, maybe the primary and secondary, maybe due to thyroidectomy, where this parathyroid gland is actually removed along with thyroid glands. Pseudo-hypoparathyroidism, here resistant to parathyroid hormones, where the hormone is secreted but the receptors defective. The deficiency of vitamin D, maybe that's because of maybe limited exposure to sunlight, malabsorption, diet deficiency, liver disease, kidney disease, so vitamin D resistance in the renal disease, nephrotic syndrome, maybe binding proteins lost because of this. And then medullary calcium of thyroid, increased secretion of calcitriol. Increase in phosphorus level, renal failure, phosphate infusion, renal tubular acidosis. Other conditions, intestinal malabsorption, acute pancreatitis, alkalosis, decreasing ionized calcium, deficiency of iron. And the treatments in the drugs, bisphosphonate and calcitriol administration. Clinical feature includes, this clinical feature is due to increased neuromuscular irritability. This is actually manifested as paresthesia around mouth and in fingers, muscle cramps, carpal symptoms can be cited, tetany, seizures, bradycardia, and prolonged QT intervals, Chaucer sign and Chaucer sign. This is actually when we apply the cups here with the 20 millimeter mercury pressure, where we can see the carpal spasm. Chaucer signs when we put some mild pressure with the finger here on the below the earlobes, so we can observe some changes in the contraction of the corner of the mouth. That is actually, you can show this deficiency of calcium. This is explained how this carpal spasm is cited. Blood pressure in the cup is applied, 12 millimeter mercury, and the systolic blood pressure level. This extra blood flow to the hand is slightly reduced or occluded for 3 to 5 minutes, and then leads to carpal spasm. The flexion at the wrist, flexion at the metacarpal phalangeal joints, extensions of the interphalangeal joints, and adductions, thumbs, fingers. This one is Chaucer sign. Here in this case, when you apply pressure on the below the earlobes, this response will be like twitching of the lips at the corner of the mouth. Maybe or in the most of the facial muscles. That depends upon the severity of hypercalcemia. Now we come to hypercalcemia. Hypercalcemia, and the serum calcium level exceeds more than 11 milligram per DL, it is called hypercalcemia. Process includes hyperparathyroidism, because excess parathyroid hormones causes more of calcium in the blood. This can be primary hyperparathyroidism, is the most common. Other conditions of malignancy, the increased secretion of PTH, multiple myeloma, patches, disease, metastatic carcinoma of bone. In multiple myeloma, what happens is there is a calcium release from the bones. So, granulomatous disease like sarcoidosis, thyrotoxicosis, renal failure, benign familial hyperglycemia, long similarization or lack of exercise, bedridden, milk alkali syndrome, or such as vitamin A intoxication and hypervitaminosis D, drugs such as thiazide diuretics and lithium. Hypercalcemia causes under. Now let's look at clinical features. Hypercalcemia causes progressive depolarization and action potential of cell membrane of nerve cells. Symptoms depends upon the severity of hyperglycemia, nausea, vomiting, abdominal pain, confusion, depression, psychosis, polyuria, polydipsia because of ADH anachronism, hypertension and shortening of QT interval, osteoporosis, and pathological fractures because the bones are liable to fractures. Renal stones that forms calcium stones, what is called calculus, and ectopic calcification and pancreatitis. Ectopic calcification means the calcium is put into some soft tissue, even arteries and serum calcium and phosphorus. Increased phosphorus with decreased calcium, hyperparathyroidism, and renal disease. Increased phosphorus with the normal increased calcium, milk alkali syndrome, hypervitaminosis. This we'll see one more time along with the phosphorus. Serum calcium with the protein and pH. Serum albumin in hypoalbuminemia, particularly in liver disease, the total calcium is decreased, but not the ionized calcium. So there will not be any deficiency manifestation. Alkalosis, the fat is binding about calcium protein, so providing of ionized calciums. Total calcium level is normal, but that's ionized calcium is reduced there, so the deficiency may be. Acidosis. Acidosis favors ionization of calcium. Inoscation, how to inoscate calcium disorders, whether hypo or hyper. Biochemical inoscation are helpful in evaluation. Serum total and ionized calcium. So we can go for total along with ionized calcium. Serum phosphorus, plasma intact ATH. So we can see parathyroid hormones, estimation. Vitamin D, that is 25. Hydroxycholecalciferol, that's the form we estimate in case of vitamin D, alkaline phosphatase, serum creatinine, serum bicarbonate, serum magnesium, X-ray of metacardial and ECG. That's all about calcium metabolism. Now we'll go into phosphorus. Phosphorus I have used two different spelling. Both are in the use. Now we can find two phosphorus. That is PHOS, PHO or US. The total body phosphate is about 1 kilogram. Out of this, 80% is found in the bone and teeth, 10% in the muscles and blood. Remaining is found with phosphates compounds. Phosphorus mainly intracellular ions. RDA. This requirement is about 5 milligrams per day. Milk is a good source of phosphorus because phosphorus is present along with calcium in most of these sources. Cereals, nuts, and meats are moderate sources. Again, vegetarian can go for nuts and cereals. Calcitriol increases phosphate absorption. The absorption takes place at region. Serum levels. Normal level is 3 to 4 milligrams per day. And the children is slightly increased, that is 5 to 6 milligrams per day. Fasting level is the plasma phosphorus is on the other side, but in the postprandial conditions, the phosphorus level is decreases due to utilization of phosphates for metabolism, phosphorylation reaction. In the serum, it's present as monovalent, and the bivalent phosphate signs are present. In plasma, a ratio of 1:9 in alkalosis, a ratio of 1:4 at pH 1.4 and at a ratio of 100:1 at pH 4.5 in urine. Now come to function. We'll take a look at various functions of phosphorus. Phosphorus, again, the formation of bone and teeth along with calcium. This is a part of high energy phosphate compounds such as ATP, CTP, GTP, etc. That means now electrolysis releases a lot of energy. For example, ATP, it's basically a form which we use, and releases 7.3 kilocalories per mole. Since it's a various nucleoside, coenzymes such as NAD and NADP. Since it's a DNA and RNA, formation of phosphate esters such as glucose phosphate, formation of various phosphate proteins, for example, casein. Phosphorus is required for phospholipid synthesis, activation of enzymes by phosphorylation, phosphate buffer system in blood also required phosphorus. The ratio of Na to HPO4, that is disodium hydrogen phosphate to sodium dihydrogen phosphate in blood is 4:1 at pH 1.4. That ratio is important for maintaining pH. This is one of the blood buffers, sorry, cellular endocellular buffers. Disorders: hyperphosphatemia and hyperphosphatemia. That means that hyper means is a decrease lower than the normal, and hyperphosphatemia higher than the normal. Hyperphosphatemia, that is decreased absorption of phosphates in case of malnutrition, malabsorption, chronic diarrhea, vitamin D deficiency, endocellular shift, insulin therapy, respiratory alkalosis, and increased urine excretion, hyperparathyroidism, Fanconi syndrome, and hypophosphatemia rickets. There's one condition where there's low phosphates, hereditary hypophosphatemia. Certain drugs reduces phosphorus levels, and anesthetics, diuretics, salicylate. Hyperphosphatemia, in this case, there's increased absorption of phosphates, for example, excess vitamin D and phosphate infusion. Increased cell lysis, for example, chemotherapy of cancer, bone secondaries. Decreased excretion of phosphorus, renal impairment, hyperparathyroidism. There's hypocalcemia, massive blood transfusion, thyrotoxicosis, certain drugs, the chlorothiazide, nifedipine, furosemide. These all cause hyperphosphatemia. Changes of phosphorus with the calcium in plasma. Increase phosphorus with decreased calcium. So this kind of things we can find out this actually happening. Hyperparathyroidism and renal disease. Increased phosphorus with decreased calcium in these conditions, hyperparathyroidism. There should be disease. Increased phosphorus with normal or increased calcium. Again, that's hypervitaminosis of the milk alkali syndrome, decreased phosphorus with increased calcium, hyperparathyroidism, sarcoidosis, decreased phosphorus with decreased calcium, malabsorption, vitamin D deficiency, renal tubular acidosis. Now we come to the part of this calcium phosphorus metabolisms, along with the osteoporosis. Osteoporosis. This is progressive skeletal disorders, bone disorders, characterized by low bone density and deterioration of microstructures of skeletal tissue. What is called this is here actually the bone mineral stiffness affected. That means decrease in bone mineral and bone density. That is nothing but demineralization of bone. It is associated with increased risk of fracture because the bones are prone to fraction, very fragile for bones. Common sites for osteoporotic fractures include the spine, wrist, and hip. Risk increases in older age as age advances as calcium absorption declines. Postmenopausal women are prone to osteoporosis because of withdrawal of estrogen. One way we can avoid this can take it off by leading healthy lifestyle. We do not know the exact etiology, but many factors are known to be involved, play a role in osteoporosis. Sedentary lifestyle and lack of exercise are risk factors. Risk increases in older age as calcium absorption declines, as well as said. And postmenopausal women are prone to osteoporosis. That is because they are protected in the early perimenopausal. The estrogen is kind of repeats. So to osteoporosis to avoid, one can have a healthy lifestyle, balanced diet, and doing regular exercise, and can avoid this kind of bone disorders. Thank you.